This is Monday, April 21st, meeting of the Community and Public Health Committee meeting.
I will take the roll. I'll start with you, Commissioner Dorado.
I'm here.
All right, and Commissioner Salgado.
Present.
All right, and I'll note that Commissioner Christian is on her way. I will start with the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the March 17, 2025 committee meeting minutes.
I motion.
Any public?
Yeah, is there any
No.
public comment in the room on this item? All right, so all in favor?
Aye.
Great. So we can move on to item 3, the San Francisco Health Network primary care update. I will pull up the presentation. Dr. Gregory? Is Dr. Gregory with us remotely? Aman, do you know where Dr. Gregory is? We can certainly start with the other presentation. I'm sorry, I'm not able to hear you.
She's supposed to be there in person. She may be in transit. I can quickly text her really quickly if you want to move with the next presentation.
Sure.
She's planning to be there.
So everyone else in the next presentation, are y'all ready to go? Is it okay? Okay, thank you. We'll just switch it around.
Great.
Give me 1 second to switch the presentation. Okay, so we will move on instead to item 4, the 2024 San Francisco Community Health Assessment. Okay, yes.
Good afternoon, Health Commissioner.
Oh, actually, it'll bend down to you. Yeah.
Thank you. All right. Good afternoon, Health Commissioners. My name is Priscilla Chu, and I'm the Manager for Public Health Accreditation and Staff Engagement and Wellness for Population Health Division. And I am here with my colleague, Seth Pardo, Director of the Center for Data Science, to present the 2024 San Francisco Community Health Assessment, also known as the CHA. Next slide, please. Before describing the CHA and its purpose, I'd like to share about the CHA collaborative process. So this process has both internal and external partners. Within DPH, we are the Population Health Division under Dr. Susan Phillip in the red square. While PhD led the CHA process, we worked with many across the Department of Public Health, and these partnerships included the Office of Health Equity, Maternal Child Adolescent Health, Zuckerberg, San Francisco General Hospital, and Behavioral Health Services. Next slide, please. Within our own division, there were many collaborators also. The writing team was made up of members from the Operations Branch, the Center for Data Science, and the Administration, Policy, and Performance Branch. We received input and used reports from PhD branches, including the Center for Public Health Research, Applied Research, Community Health, Epidemiology and Surveillance, STI HIV branch, the Office of Anti-Racism and Equity, and Community Health Equity and Promotion branch. Next slide, please. In our presentation today, we will describe the purpose of the CHA, how we did this, and we will also present high-level key findings of this dense report in the themes of resilience amidst crisis, persistent challenges, and social determinants of health. After that, we will share our next steps. Next slide, please. The CHA is not a new process for San Francisco. It's been published periodically since 2012. This 2024 CHA is a point-in-time snapshot of the health of San Franciscans and offers a broad view of the city's health landscape, analyzing several health status indicators and conditions and highlighting the challenges and triumphs that have emerged since the last assessment in 2019. The report includes detailed statistics on disease prevalence and mortality, as well as insights into the needs and resources within San Francisco communities. The 2024 CHA is an iterative process done on behalf of all DPH. The CHA results inform other upcoming planning processes, such as the Community Health Improvement Plan and the strategic plans for DPH and PhD. These processes will start once we have presented the CHA. Furthermore, the CHA is a requirement for public health accreditation, and 2 initiatives from the state also require CHA data. The Department of Healthcare Services, California Advancing and Innovating Medi-Cal, or CalAIM initiative, wants CHA data every 3 years. The California Department of Public Health has a Future of Public Health grant that wants data annually. The full Future of Public Health report is attached as a supplementary document to this presentation. Next slide. So this was a process with quantitative and community data and in partnership with many external partners. The 2024 CHA employed a mixed methods approach, integrating data with the intent to provide a balanced view of community health status among San Franciscans. For quantitative data, they were mostly from 2017 through 2022. Data regarding COVID-19, the coordinated overdose response and engagement, and MPOX outcomes are presented through 2024. Data originated from multiple sources, including public health surveillance data, SFDPH community surveys, and secondary data sources, such as the U.S. Census Bureau, the California Department of Healthcare Access and Information, and the California Health Interview Survey. In addition, published third-party reports, their findings were also incorporated into this report. Community engagement data came from San Francisco community members. Qualitative insights were gathered from over 450 participants through 20 focus groups, 18 interviews, and over 120 long answer surveys. The data also reflect community engagement by the San Francisco Health Network and the Office of Health Equity. In addition to internal stakeholders mentioned in the org chart slides, we also had external partners. The creation of this report was a collaborative effort that brought together a diverse array of contributors. These partnerships fostered data collection and community relationships. Next, I will turn the time over to Seth.
Good afternoon, commissioners. Today I will cover the high-level data findings, and I'll begin sharing of this the mortality data trends, and then I'll share a strong success story, and then describe some of our most persistent health challenges. I'll describe some of the most impactful data that are included in the full report that we shared with you here in advance. Next slide, please.
Goes it back.
There you go. Perfect. The top 10 leading causes of death among San Francisco residents include the same 10 conditions for the 2024 report as were reported in the 2019 Community Health Assessment. As shown here, deaths due to drug use disorders jumped from the 8th ranked position to the 2nd ranked position. And in fact, drug use disorders had the largest 3-year growth in mortality rate between 2019 and 2021. The rate increased 38.8%. By contrast, while there was enough worsening among ischemic heart disease for it to remain in the #1 ranked position among the leading causes of mortality, ischemic heart disease had a 3-year growth in mortality rate of 17.5%. This is a growth rate that's less than half of what was observed for drug use disorders. Next slide, please. Resilience starts with community and the strengths therein. San Francisco is a robust community in the face of emerging public health challenges. This particularly applies to the city's responses to novel infectious diseases such as COVID-19 and Mpox. For example, as noted by a participant in our SF Voices focus group, quote, "The way we all come together and work as one, as well as always staying rooted in our culture and sharing our culture, helps foster and strengthen the bond between different communities." Recent data show improved health outcomes for preventing infections and hospitalizations for several conditions. And here we highlight the decreasing number of new HIV diagnoses between 2014 and 2023. As shown here, new HIV infections are down 60%. This is the lowest number of new HIV infections in the past decade. Next slide, please. Mental health is also an important concern across community members interviewed for this report across a range of ages from youth and adolescents to adults. The California Health Interview Survey measures serious psychological distress based on the number and frequency of mental health symptoms such as hopelessness or depression that were reported in the past year. As shown on this slide, in San Francisco in 2018, approximately 10% of adults met criteria for serious psychological distress in the past year. And by 2022, this proportion had increased to 17%. I spoke a bit earlier in slide 7 about the increasing mortality trends for substance use disorders. Drug-related deaths, for example, deaths due to opioids or fentanyl in particular, have been increasing since 2018. These are a persistent challenge. And as you all know, DPH began the core overdose emergency response towards the end of 2023. And while our collective and focused efforts are having a positive impact, we still see some stark mortality disparities by race. In fact, some of the most stubborn challenges we face in San Francisco are racial health disparities. And I'd like to show you some examples. Next slide, please. So similar to the report in 2019, the 2024 Community Health Assessment reveals that there are large racial disparities in mortality rates by cause per 100,000 residents in San Francisco. And we pool the data here between 2019 and 2021. You see, particularly among African-American residents, as indicated by the yellow bars here in the graph, compared to all San Francisco residents, which is indicated by the vertical dotted line. For substance use disorders, drug use disorders, which is second from the top, between 2019 and 2021, African-American San Francisco residents died of drug use disorders at a rate over 4 times higher than that observed for all San Francisco residents. Now, these trends are not isolated to mortality rates. Health disparities by race, ethnicity are seen across several other chronic disease conditions, such as type 2 diabetes and other social determinants of health, which my colleague Priscilla will speak to more about now.
The social determinants of health are the structural determinants and conditions in which people are born, grow, live, work, and age. Also known as SDOH, they are increasingly recognized as important contributors to health outcomes and can exacerbate health outcomes for chronic diseases such as heart failure and diabetes. Community focus groups identified systemic barriers to health and disproportionately affect marginalized communities. These barriers include access to culturally and linguistically appropriate services, affordable, healthy foods, affordable housing, and safety concerns. Hospitalization rates due to diabetes, hypertension, or heart disease were higher, 9 times higher for Pacific Islander residents and around 4 times higher for Black African American residents compared to the citywide average. Hospitalization rates due to heart failure are highest among residents of Treasure Island and Baby Hunters Point, as shown on the map. These populations and areas traditionally have been underserved and under-resourced. Next slide, please. While the 2024 CHA is a look back on the past 5 years of health in San Francisco, we will now look ahead. In preparation for the CHIP, we will distribute the full report and conduct report backs to the community, also known as the CHA Roadshow. This CHA is a foundational document done on behalf of SFDPH. As such, the CHA will inform the start of our action planning process that's known as the Community Health Improvement Plan, or the CHIP, as I mentioned. And once the priorities of the CHIP are established, involved organizations will align their strategic plans to ensure coordinated collective efforts for addressing community health needs. While the next CHA is scheduled to be published by the end of 2028, we intend to start our planning soon after this CHA's completion and will be working to engage partners in the planning process. In 2028, the CHA, the Community Health Needs Assessment, and various population needs assessments will converge into one report. Next slide. We want to acknowledge our partners who contributed to this report. And we also want to thank you, health commissioners, for having us present the CHA today and for your time. Thank you.
Shall we check for public comment real quickly? Is there any public comment in the room on this item? All right. So everyone has 3 minutes and the comment is about this item. Okay, great. Please step up and I have a timer. A bell will go off when you have 30 seconds and then the final bell will mean that your comments are done. Please.
Thank you.
Yeah. You may begin.
I'm Fanny Lam, Executive Director of APA Family Support Services. I'm also the co-chair of Asian Pacific Islanders Health Parity Coalition and the co-chair of San Francisco Health Improvement Partnership, SFHIP. And I really appreciate Nana and Seth has been joining our meeting as SFHIP to share the data with us and also be part of our CHNA that we do for San Francisco. As the team mentioned, the San Francisco Health Plan have a CHNA, and the CHA right now is 2024 CHA and 2025 CHNA. And because of the pandemic, we were not able to sync our program together. And we're really looking forward to 2028 that we can sync our programs and our report and our data together to serve better the community of San Francisco. Thank you so much.
Thank you. Is there anyone else?
Hi, my name is Alex Mitra. I'm the Director of Community Health, Gov Relations, and Volunteer Services at St. Mary's in St. Francis. And I too would like to thank Nana and Dr. Okoye and Dr. Susan Phillip for directing her staff to join the San Francisco Health Improvement Partnership and partnering with us to coordinate both the CHA and the CHNA so that we could both information share, we could use focus groups that we did with seniors, funders, and clinics and share that with the CHA, so that information could be included in the CHA. So very much appreciate the coordination and look forward to our continued work together. Thank you.
Thank you. Anyone else? All right, that ends public comment. Thank you.
Thank you for the presentation. Very informative. I just have a couple questions. On slide 10, where you're showing leading cause of death by race and ethnicity, Black African American is really high. And I just want to know, because the population of San Francisco is only 5 to 7%. So are any of these numbers maybe people that come outside the county? So that's crazy.
These are all data based on San Francisco residents.
That's insane when the population is only 5 to 7%. My second question is, as an Indigenous Latina, when you fill out paperwork, sometimes you don't know what to put. So when it says Latinx and white, because sometimes our only option is to put white, what are the questions that you're asking on how to find out what the race or ethnic background is?
Yeah, these are based on hospitalization data, so the data that is collected by the hospital.
So it could be a guess sometimes then.
The policy or that the people use their own voice and their own identification and give that to the provider who's taking the information from them. But I can't speak to the policy or.
So is it like a separate two questions, like your race and then your ethnic background, or is it all in one?
Is it one question for Latino and the whole race?
Oh, could you come up to the microphone? And I didn't do a great job of asking everyone to say their name and title. So would you mind just going back
Dr.
to
Seth Pardo, the director of the Center for Data Science, and I'm going to introduce our health equity team lead who helped supervise the analysis for the CHOP.
Thank you.
Kayla Plank, Program Manager for Health Equity Program and Center for Data Science. So this hospitalization data is provided to us by the California Department of Health, HCI, Access Information. So I'm not quite sure how they collect that race ethnicity data, but I can get that information for you if that's of interest. But my understanding is it's reported by the hospitals to the state, so they might have some requirements on how that's provided. But I can't tell you specifically those questions right now.
Okay, thank you. I would like that information because I think it makes a
And
difference.
please forward it to me whenever you do get it. Thanks.
Thank you. And that's it for me.
Okay, I have a couple of questions as well. On slide 8, do you have, may not be able to answer it, but I'm gonna raise it anyhow. Do you have any indications of the federal funding decrease, elimination in the areas that are listed on the slide, since there's been a lot in the press?
Good afternoon, Commissioners. My name is Eduardo Sida, Director of Administration, Policy and Performance for the Population Health Division. And so a great question. The answer is we don't know yet, but we are working with multiple stakeholders within DPH to assess the fiscal impact, but also other external partners such as the Controller's Office and others to see what's the impact to the city and county of San Francisco. But once we receive more information, we'll be able to report back to the Health Commission.
That'd be great. Do you have an indication, for example, that the people, I know I'm getting off here, that who would be giving you this data, let's say from CDC or wherever, that in fact those people are employed and are able to gather data to be able to give it to you? My understanding and reading further is both HIV and Mpox. It's been pretty, their staff is very limited currently. I don't know if you have any more information, but it's just of concern since San Francisco, especially in Mpox and HIV, has been a national leader. If we aren't able to get information, do we have somehow a plan B if in fact we're not going to get X dollars?
Yeah, that's what we're trying to currently plan. There's not a lot of information, as you had stated, both with the federal funding cuts, but also the layoffs that the CDC is experiencing. But we're trying to assemble a type of strategy team to really kind of help us maneuver this uncertainty times.
No, I appreciate that. I just didn't know if in strategic planning, there is a plan B for a 30%, 50%, 75% cut. I preempt these things in planning. Dr. Phillips.
Good afternoon, Commissioners. Yes, Susan Phillip, the Director of the Population Health Division and the Health Officer. So what you're voicing is really our current big concern about a lot of the core functions in public health. And San Francisco has long been very successful in getting competitive and categorical funding appropriated by Congress to CDC and then to San Francisco directly. So we're waiting to hear what is happening there. We are also very fortunate in San Francisco, through your support and the support of the mayor's office, to have some general funds to work from as well. So our plan B is going to be to try to understand what are the core functions, how do we maintain them, and certainly communicable disease surveillance to prevent outbreaks, to prevent worsening of epidemics is a core function. But I will say that, as Director Sita said, we're all very concerned, and something will have to give. And sort of the extraordinary way in which we've been able to document and ensure programmatic feedback of data and success, we'll have to see what the implications are for that. But we certainly are thinking about it and trying to do what we can to shore up core epidemiology and other core services.
No, I appreciate it. And I know this is not on here, but one of, in fact, I don't know if anybody in the audience saw the 60 Minutes presentation last night on the bird flu. And the part, it was interesting, the virologists that they were interviewing are now in Canada. And then, but that, I guess the other reason of where I'm coming from is the CDC group that has been looking into bird flu and the transmission, et cetera, has all been eliminated. So that was also part of my angst in asking this question too. So, okay. And I have one other question, and I know it was kind of alluded to, but I think the present that with the recommendations and goals for the 2025 CHIP in the strategic plan going forward, since I'm assuming it's in process, will it be communicated? I think from what I heard in it, that it will be communicated back to us in some way, that what the 2025 agreement goals would be.
Hello again. My name is Priscilla Chu, just to remind you. Yeah, so we purposely or intentionally did not make recommendations or goals for the CHA because we wanted to wait for more community input to figure out the priorities for the CHIP. So it'll be based on the CHA, and that's part of the CHA Roadshow where we share that back with community. And then we'll do a brief survey to ask them for their input on what the priorities are after they've heard the report back presentation.
Okay. And I know this is getting too detailed possibly, but what part of the year then do you get the information for you and your staff to be able to formulate the next steps?
Right. So the next step would be to start the CHIP process. Our report back is actually starting next month. We are waiting for this meeting to get the roadshow started and making sure that the child looked okay before we shared that out further. And we hope to finish the CHIP process by the end of the year. And it's a two-phase process where the first phase will be developing the high-level plan and then to work with individual partners for collective impact to see what parts of the strategies that we come up with that they would be willing to take on.
Well, I appreciate it, and thank you. But it would be helpful, I think, since your community assessment report is so important to, overall public health and what our charge here. I wouldn't ask you for a full presentation, but just maybe 2 slides, since of letting us know what the plans are going forward based on, I guess, just my voiced concerns between now and the end of the year. Who knows, is what we might be dealing with. So if that's possible, to just get back to us with something, just what you're.
An outline of the plan.
Pardon me?
An outline of the plan through the end of
Yeah,
the year?
yeah, just,
Okay.
one or two slides, not a big presentation, just, I think from our concern for the department and what our, focus is, we want to be very supportive, but also want to have, the knowledge. So if members in the community ask us about it, we are fully aware of what the, strategies and what the goals are based on the financial challenges. So it would be helpful.
Yes.
So I want to just clarify if I can jump in. So Commissioner, this is the community health assessment you're talking about. And then separately, the commission will be getting updates from probably Dr. Phillip as we know more about funding and how that might impact core services, right? So that's two separate. I'm going to make sure we're parsing out
Right.
the two
I
separate
just,
things.
for an overall health, based on what you had put down as the priority areas, that you're focused on, I think sometimes what we do, love to know is wonderful presentation. What's your next steps so that we like to go from, one to, just to see the full picture of where CHIP and the CHA are integrating.
Yes.
Thank you.
Thank you. Any other comments or questions?
Yes. Thank you. Thank you for the presentation. I'm sorry that I was a little bit tardy. Apologize for that. One of the questions that I had was looking at the data from 2017 versus 2019-2021 on slide 7, and what any comments that you have or thoughts you have about my question and what you think you're going to be seeing, you may be seeing going forward regarding the neurodegenerative diseases. I think there may have been a question about the Alzheimer's drop from 3 to 6, and that may have been answered. But just from reading that I've done in the last year about kind of marking the rise of, first of all, there's long COVID, the effects of COVID, and the neurodegenerative aspects of the symptoms that people have been experiencing. And so it seems like there has been a rise in the number of people affected and diagnosed in these areas. And I'm wondering if you may be already seeing that or thinking about that, or what you might, if you have any thoughts or expectations about what you might be seeing going forward. And given the many completely unknown effects until now that doctors are attributing to COVID infections, the aftermath of COVID infections, whether there's any intent to focus a little more granularly on those possibilities and people who've been infected and who their doctors may have thought that perhaps they had some kind of longer course of effects from those infections. Just wondering about the neurodegenerative disease category. Don't know whether you have anything to say about that right now, but that's something that I expect we might be seeing more of in the coming reports. Dr. Phillip, hi.
Thank you, Commissioner Christian. Good afternoon. That's a very good question. Neurodegenerative diseases are not an area in which we get systematic surveillance and reporting. So that is a particular challenge. And again, in the current climate, we're unlikely to be able to start a new line of investigation into it. But I think what we will be working to do is try to understand how we can better utilize electronic health records and data exchanges that the state is putting into place with all the health systems, including the San Francisco Health Network. So we'll be able to better utilize some of that data that is already being captured.
Exactly.
And hopefully that will help increase our understanding of some of these other conditions. We also really recognize that we want to be able to increase our epidemiologic capacity to understand non-communicable diseases as well as communicable, especially given that ischemic heart disease is remained so high, number one among the causes of mortality for San Franciscans. So this is an area of work. It's not going to be built overnight, but we are going to be moving to trying to utilize all the data that are available with current strategies, new strategies, and then try to understand how we can better describe that to this commission and to the public.
Thank you. And I was hoping and assuming that what you've just outlined is true, that, we're talking about California residents when we're talking about San Franciscans. And so theoretically, there is data that's there. Just figuring out how to capture it and distill it will be the new pathway that you will have to create, right?
Correct.
Well, at least it's there, and at least we have you all in charge of it so that we have some confidence that what can be done will be done. And, picking up on Commissioner Salgado's comment about the continuing alarming and distressing discrepancies between African-American, Black African-Americans, and the other members of the population here in San Francisco. It was good to hear just a couple of public comments about the increasing collaboration from individual organizations, community-based organizations with the department, collaboration and giving information, feeding information. Are there, and the focus groups things, I'm sure that has been happening, and glad to hear that it is spreading. Is there it sounds like there's an intentional thought process toward getting more information from people in the community and making sure it comes up to the department level. And I don't know whether there are, it would be interesting to know how that might be progressing in the coming year, because it seems like it's a really important source of information about what's happening to people and why, from their experiential perspective, these diseases are so high. We're looking at slide 11 on the social determinants of health. Safety, that is kind of an amorphous and broad category. And it would be interesting to know, and perhaps it is in the larger report, what falls under that category for people from their perspective. I would imagine that one of the effects of not feeling safe is stress. And there's so much stress that is placed on people, particularly Black and African American and people of color and other marginalized populations here in the city that feed into these disparities and these discrepancies. And so I know that the department is fully aware and focused on these things, and in the community health aspects are doing everything that you can to address these things. But it would be really, I think it would be helpful to have perhaps a more granular presentation on what we are doing and how we're collaborating with the community to get at the root of exactly the source of these things and how we can address each of those aspects to try to decrease this level of just harm that's happening in the community. And that would be helpful for us to know, and for us to engage with you about, and for the community to know as well. Again, I'm happy to hear anything you might have to say about that, but don't expect you to respond right now. Also, I want to thank you deeply for the organizational charts. It's always extremely helpful to us. It may seem silly to you, but it's extremely helpful for us to be able to picture the department and the way it's working, and who works with whom, and who we're talking to, and what they do, and who they work with. So it's really, really helpful just in helping me, I'll just speak for myself, getting my head around the work that you're doing, and it helps me to understand it. I know it's kind of the last thing that you want to have to think about as an organizational chart, but it really is, it's helpful. So thank you so much. And the other thing that I wanted to ask about, just to put a pin in something, is on the drug use disorders. As we think about this, we're very focused, understandably so, on fentanyl right now. But it seems like in the things that we discuss and the literature that we get, there's less discussion about meth. And it's my understanding from the little reading that I do as a non-physician about this, that meth continues to be a huge problem in conjunction with fentanyl and other narcotics in overdoses and also in the spread of other diseases. And so it would be interesting for us to be educated continually about that interplay to the extent that it does exist and how it does change. Those are the comments that I have. Thank you so much for this presentation, and even thank you more for your work. It's so important, and we would love to continue to support you in any ways that we can.
Thank you. And Commissioner, I'm going to note, and I'll speak with Dr. Phillip, but some of the issues you talked about are department-wide in terms of how the department will respond. So you and I can check and see, and I don't want to put the onus on the folks in the room because it's a larger.
But no, I understand that. I expect that all of this is department-wide, and
Sure.
we were lucky today to have these fine people in front of us, and so we're talking to them.
Great. And before we move to the next item, I just want to personally thank the folks in the room and the work that you do. The folks at Population Health are sometimes not highlighted in articles in the paper and aren't held up because you all do a lot of infrastructure work and behind the scenes. I just know how important everything that you do is. The commissioners also know and appreciate it. But as somebody who works beside you, I just want to make sure that you know that we value you, especially during these stressful times.
May I say?
Of course, yeah.
Thank you so much, Secretary Morowitz. And I do want to give so much credit to this team, and there are others as well, but this is really a large part of the core team that has made this report happen. And as Dr. Chu said, it really is on behalf of the entire department. So it's our honor to do it as PhD, but we are doing it as representatives of you all and the entire department. So thank you so much for your support.
Great.
We all thank you too. I mean, it's excellent, but it also really helps us to see what, the current issues are, just like drug use disorder. We always thought it probably was higher, but you've got the information that is so helpful. So I know it's a lot of work, and pulling this all together between CHA and CHIP and CHIP integrating into CHA, but that it's really extremely helpful, and we're very grateful for your hard work.
All right. Thank you, Commissioner. We can move on to item 3, the San Francisco Health Network Primary Care Update. Welcome. And please just let me know when you need the next slide.
Great. Good afternoon. So wonderful to see you. Thank you. And I apologize for my tardiness as well. I was patiently waiting at 101 Grove to get started. So as force of habit, I apologize for my mix up. But I'm Blake Gregory. I'm the Director of Primary Care. Secretary Morowitz, how do I advance the slides? Or what you'll, okay, great, wonderful. So, but I'll be sharing with you sort of updates from primary care since I met with you last year. So we can advance the slides. And speaking of org charts, just as a reminder about where primary care sits, we are part of the San Francisco Health Network, which is overseen by Roland Pickens. And specifically, we are part of the ambulatory care division. And our new CAO is Amin Lail. And then there's primary care, which is our department. So we'll keep on going. And just a little bit about our budget and funding sources. We derive about 30% of our funding from billable encounters, Medicare, Medi-Cal, and followed by that, we get a significant chunk of money from the Quality Incentive Pool, which is a Medi-Cal Pay for Performance program. And that is followed by the Global Payment Program, which is a DHCS program that sort of pooled funds from state and federal sources to cover care gaps for patients who are uninsured. And then in terms of our sort of costs and expenditures, about 3/4 of our budget goes to salary and fringe, and then the remaining is operating costs. And then I think just to say a little bit about primary care, we're a very large section, so we have about 650 FTE of staff. And of that, we have over 100 permanent vacancies in our department. So we'll go to the next slide. And this is just a little bit more about budget and finance. So we have our data broken down by billable and non-billable encounters. So across all of primary care, all 14 sites, we had a total of 273,000 encounters. That's the combination of billable and non-billable. And then of those, when you break down by billable, we had over 166,000 billable encounters over the past year. Next slide. And this is just a little bit about our patients and their demographics. And, I think just there were some questions about race and ethnicity that came up with the prior groups. I'm happy to speak to that during the Q&A, but we have separate questions for race and ethnicity. And so this is just the breakdown that you can see. For ethnicity, about 44% of our patients identify as Latino, Latinx, and then the remainder not. And then we have a sort of breakdown, this other category under race and ethnicity, 45%. That is largely that cohort of patients that identify as Latino, Latinx, biracial, or other categories not otherwise specified, followed by Asian and then white. And then our most common language is English, but that's followed closely by Spanish. Then you can see the sexual orientation and gender identity data here in the slide. So we'll keep on going. And then just a little bit about our sort of geography. Primary care is composed of 14 clinics. We really are situated throughout the city in neighborhoods where our patients live and work. And that's what we want. We really want to provide low barrier access where it's easy for patients to get to us from the neighborhoods that they live in. And so we are all over the map. We're in the Tenderloin, which is where I see patients. We're in the Mission, Excelsior, Bayview, Outer Sunset, Western Addition. So we're really all over the place, just wherever our patients choose to seek care. Next slide. And when I came to present to you all last year, I was fairly new to the role, but at the time I had shared a really high-level vision about 3 critical areas where primary care felt like were our priorities and areas of focus. And those were around building meaningful structures around anti-racism and equity, improving access to care, and building a culture of integration. And so we've done tremendous work in these 3 spaces. Since I last spoke with you, I'm really excited to be able to share that progress with you today. And the rest of the talk is really structured around these key domains. And then I'm excited to also share with you a vision and mission statement for primary care that was truly co-designed by everyone in primary care at our annual meeting that consists of over 500 staff members coming together. And so we did an activity at this meeting to co-design a mission and vision together. So I'll share that with you, which is proudly providing team-delivered, affirming, whole healthcare, sustaining each other and our communities with respect and belonging. Next slide. So let's start by talking about a lot of the work that we've done in the area of anti-racism and equity. Next slide. So there are a few key domains in which we've been focusing around anti-racism and equity. One is around quality of care and quality outcomes. And what are the things that we can measure in order to continue to reduce our disparities, improve outcomes for all of our patients? And so we're very fortunate to have a really robust data infrastructure and a robust quality improvement team that really works around the clock to analyze and develop interventions to improve our health outcomes. And so what I'm showing here is some focused work we've done this year around well-child checks. We know that we have disparities in this metric. And so we'll specifically talk about well-child checks for school-age kids from 6 to 11. And so the way we sort of approached this work starting last year was really doing sort of an intensive analysis about where our gaps are, what are some of the drivers, sort of engaging patients in this question, and developing interventions to better track are patients who are falling behind. So patients who are lost to care, they just haven't been in for a well child check in a while, or maybe they no-showed to their last appointment, really trying to lower barriers. And so we've been partnering with San Francisco Health Plan to develop an incentive program for families that show up to their well child check, just to provide an incentive. We've done a lot of work around transportation to help patients get to their visit, because transportation is a real barrier for a number of our families. And then also very proud to share work that's been done at the Children's Health Center. It's a program called the Honeycomb Clinic, which is a clinic that is really centered around racially concordant care. And so Black families that prefer to work with a racially concordant provider have that option with this Honeycomb Clinic, and they can work with a Black provider that they may feel more trust or may identify more closely with. And so the Honeycomb Clinic is, something we're very proud of, and has done really tremendous work. And so with all those interventions combined, we've been able to increase our rate for Black African American children in this age group by 6% and get closer to closing our gap. A gap still remains, but we have made significant progress in this area. So we'll go to the next slide and talk a little bit more about data, but also sort of the qualitative way that we can approach data. When we think about disparities in our health outcomes, there's sort of the numbers. What do the numbers show us? What are the metrics? What's the data? And that tells us part of the story, but actually not the whole story. And so I'm really excited to share this data from our care experience team. We, for years with our patient satisfaction surveys, have asked a question around bias in care. So a patient would come in for a visit, and then following that, they'll get surveyed with a question: did you experience, were you treated respectfully and without bias against your race, ethnicity, or other personal traits? And this is really, really valuable data to look at. What you're seeing here is our data response to this question broken down by clinic, and there is a significant spread, and that tells us a little bit more of a story than if we just had all that data aggregated. So there is a difference in the experience our patients have. And then when our team kind of took this data, they did an even deeper dive and did a number of structured interviews with patients and staff members, again, to try to drill down what is behind this question, what is driving it, what is it about the patient's experience that leads them to feel that they may have been treated with bias. And so we've learned a lot of really interesting things from that qualitative analysis and just from going out and talking to people. We've learned about sort of interpretation. Was interpretation used? If it wasn't, sometimes that can lead patients to feel like they were treated with bias, or if the quality of the interpretation wasn't very good. We've learned things about various touch points that patients have through our system, whether it's their interaction in the waiting room or with their provider or when they seek specialty care. And so this has been a really rich source of data for us to sort of look at the quantitative and the qualitative and use that to define countermeasures that are actually going to be impactful and meaningful for our patients. So this is another way that we really try to meaningfully approach anti-racism and equity, is looking at bias. Next slide. And so now I'm going to shift gears to another priority of focus for us in primary care, which is improving access to care. This has been such a critical area for us. I'd say this has really been a 3-year project, and we're very far along in terms of our interventions for access to care, and I'm really excited to share this data. We feel deeply that access to care is incredibly important to our patients, and I think it's common sense, right? If you can't get in to see your provider, it doesn't matter how great we are. We can't provide quality of care if our patients can't access our services in a timely way, and also a low barrier way. We shouldn't make it really hard and have to jump through a bunch of hoops to get in to see us. So I'll share a little bit more about our access project. As I said, we've been working on this since July of 2022, when we made access to care a true north metric. And you can see the steps in the timeline. I won't go through all of them, but I think just to say that back in October of 2023, we were placed on a corrective action plan by San Francisco Health Plan for our access, because our grievances, our patient complaints were really skyrocketing. So we were hearing from patients, and we knew this already, but patients were not happy with the level of access we were providing. And so we really, developed a project plan. We developed an A3 and set goals for our access that are centered around, of course, improving access to care, but also reducing waste. and finding ways to use Epic effectively, because there were a lot of tools in Epic that we had not previously been using that could actually make life easier and improve our access to care. And so starting in February 2024, we had our pilot site at Potrero Hill, who was sort of bold and brave and tested out a new way of scheduling patients. And we learned a lot from that and then have gradually scaled out over time. From that pilot, we are now live with 8 out of our 14 primary care sites with this new access work. And we've really seen tremendous impact. So let me just share some of the data with you now. We can go to the next slide. So third next available appointment is one of the benchmark ways of measuring access to care. And it's, again, common sense. A patient calls the first next available appointment. If that doesn't work for him, what's the second next available? And if that doesn't work, what's the third next available? So that's what we're measuring here, third next available TNAA. And what I'm sharing with you is data from Silver Avenue Family Health Center, which went live with this access work in September. And so the goal set by the state, set by DHCS for third next available is 14 calendar days or less. And as you can see, before Silver Avenue embarked on this journey, their third next available was over 3.5 weeks out. It was 25 days. And then they went live in early September. And I think you can just see that line plummet almost immediately, actually. And they've been able to sustain that change so that they haven't exceeded the DHCS goal ever since they went live with this process. And I will say, for almost all of our clinics that are live with this, this is the trend line that we're seeing, these really dramatic improvements in third next available. We can go to the next slide. And then another area where we've been doing a lot of work is around access to care for new patients. And so, this has been a problem for us for many years, especially with the pandemic and staffing shortages and trying to manage, a public health emergency. Our new patient wait times were unacceptably high. And so with a lot of interventions around standardizing our empanelment, making sure that if a provider had capacity to see new patients, that they were seeing new patients, and developing a lot of data transparency around that. We have been able to reduce the number of patients waiting for a new patient appointment by 97%. And so now with our only, about five or so clinics that have a new patient wait list at this point, and it's single digits for each of those clinics. And so in general, now we're able to get patients in within a couple of weeks. And so this is some other work we've been doing. I'll go to this last slide, which is around patient grievances. So I mentioned to you earlier that we were placed on a corrective action plan by San Francisco Health Plan in 2023, really because of the number of patient grievances that were coming through around access to care. And so what you can see in this graph is that, sort of up and down in 2023 in terms of the number of access grievances. This was both for new patient appointments and for established appointments. Up and down, but really unacceptably high in between September and November of 2023. And that was the time we were placed on the corrective action plan. And now fast forward to 2025, in January was when we went live with really with the majority of our clinics, 8 out of 14 clinics. And what you can see now is that since we went live with those 8 clinics, we've had 3 patient grievances during that period, which represents an 82% decline in patient grievances related to access. So we'll keep on going. So the last kind of bucket that I'm going to pivot to is talking about what we call building a culture of integration. And so I think, DPH may have the reputation at times about being siloed. At least historically, that is what some people have said, and primary care was no exception to that. And so we've really, really tried to be intentional about how can we really think of ourselves as one team, one system, instead of this clinic, that clinic, call center. We all want the same thing, and we're all, we can all support each other and share resources and problem solve, and we're much stronger for it. So we've been doing a lot of work just around really building this culture of integration. It's one reason why we, convened over 500 primary care staff for an annual meeting, is how do we come together and be in the same room, get to know each other, problem solve, collaborate. And so I'm going to talk about some ways where we've really, really tried to strive for integration. Next slide. And so one way is really focusing on behavioral health integration, which is really a best practice model for primary care clinics. What we really don't want is for mental health services to be siloed or set apart from primary care services. We should be working hand in hand. And for me, when I'm a provider seeing patients, if I have somebody who's in crisis, I want to walk down the hallway and be able to safely hand off that patient so that, we can provide the best and most immediate care possible. So primary care for the last 2 years has been focusing really intensely on a behavioral health integration model. We piloted this last year at Maxine Hall Health Center. And so what I'm sharing here is data from Maxine Hall. What you can see here is this data is the number of unduplicated clients served in our behavioral health services. And since Maxine Hall went live last summer, I think you can see those numbers go up and up and up and up. And so we really are able to serve more patients. We're able to provide same-day services in the form of warm handoffs, so patients don't have to come back or don't have to wait for a call. And just really being able to provide that immediacy. And it's never been more important than now, with the city facing an overdose crisis, stress at the, state, federal, global level. Everybody is feeling it. And so we're just really glad we've done all this investment in behavioral health integration. We're going live with this model at 3 more clinics right now, and then plan to scale it out to all of our clinics over the next 1 to 2 years. Next slide. Speaking of sort of the overdose crisis, we recognize CORE is a mayor's priority, city priority. It is absolutely our priority too, to reduce overdose deaths. It's an equity issue. It's, a safety issue, so many things. And so primary care is 100% coming to the table to support CORE work. Commissioner Christian, I heard you ask a question about meth use. And so we really recognize that this is a spectrum, and we shouldn't just focus on opioid addiction, because people are also dying from fentanyl toxicity when they use methamphetamine or other stimulants. And so these are just some of the programming that we have implemented in primary care. Contingency management really has the best evidence base for stimulant use. So we're very proud that we've implemented 2 contingency management programs at our sites that have the highest prevalence of addiction. That would be Tom Waddell Urban Health Center and Potrero Hill. At both of these clinics, we are also, able to offer on-site addiction specialists by board-certified addiction providers who are able to meet and support these patients. And those providers are supported by a whole care team that includes nurses, clinical pharmacists, health workers who help patients navigate. So really looking at this as a team-based intervention is really going to set us up for success. And we're also, excited to be able to offer long-acting injectable buprenorphine for patients that are eligible for that. Buprenorphine, is a great medication, but it can be hard for patients to take a medication once, twice, 3 times a day. And so being able to provide a long-acting injectable in the clinic administered by our nurses has been a really meaningful service for our patients. So we'll keep on going. And then I'll just talk a little bit more about quality improvement and just sharing some of our structures around that. So we'll go to the next slide. We're really fortunate in primary care, like I said, to have robust data infrastructure and a robust quality improvement team. We have a team of really incredible and spirited health outreach workers who come from the community, have a tremendous understanding and empathy for our patients. And so day in and day out, they are on the phone or they are in the clinics, reaching out to patients, meeting with them, talking with them. And so over the past year, this team has done 21,000 outreach encounters to try to bring patients back into care, address their care gaps, making sure they're vaccinated. Have they gotten their cancer screening? Are they up to date with their well child checks? All these things that are really bread and butter for primary care. This is the team that helps us get there. And then the data that you see, sorry, the wording is a little small, but what you can see is that is our data broken down by the sort of clinical intervention that's provided. So we've got a column for well child checks, a column for influenza, hypertension, and so forth. But I just want to make sure we recognize this incredible team that really helps us meet our targets, provide excellent care, and draw down pay for performance money that is so core to our budget through the QIP program. Next slide. And speaking of QIP, as you saw, QIP is a significant chunk of our budget, and DPH really depends on these monies to be able to pay our staff and keep our clinic doors open. The primary care team, along with the value-based care team, collaborated and worked really hard this year to draw down what we project as 100% of funding that we were eligible for. And in 2024, that amounts to $69 million. And then in 2025, that number goes way up actually to 100 million. So the stakes are very, very high. Again, we really rely on the outreach staff that I shared with you in the last slide. And of course, all the people on the ground at our primary care clinics to help us provide excellent care. And that's all that I have for us. So I'm happy to take any questions.
Is there any public comment on this item in the room? All right, there's no public comment, commissioners. It's up. It's all yours.
Thank you so much. It's great to see you. This is an amazing presentation of extraordinary work, really, really, and the improvement is it's outstanding. So thank you so much for all that you and your colleagues are doing. Going through the presentation, just starting with one of the things that you just ended with, the health workers. That's kind of a new category for at least that I'm hearing about somebody who's not involved in the provision of healthcare. And thank you for talking to us about who these individuals are and what they do. Is there anything else you want to tell us about them? It sounds like they're really very important in helping people access the care and also making sure that the care that they're accessing is sufficient for what they need. Talk about closing care gaps and things like that. Is there anything else you can add or?
Yeah, absolutely. I think what's been amazing about that group is they are incredibly versatile in what they can do. So a lot of what they do is phone outreach. Hey, you're due for your flu shot. Can we schedule you an appointment to come in? But they do so much more than that. So they staff our food pharmacies. We have 5 food pharmacies across primary care, which deliver sort of fresh produce, cooking classes, recipes, and peer support for patients with chronic diseases like diabetes and hypertension. And so they help make that happen. Another example of work that they do is around CORE. And so on the slide around CORE, you can see one of our amazing health workers, Malika Edwards, who works with me at Tom Waddell and really serves close to 500 clients with opioid addiction. I think what's amazing is the relationships that she forms with these patients. Of course, these patients have relationships with their PCP, but PCPs just aren't available all the time, right? You know, we're in the middle of seeing patients. We're very busy. So this morning I was in clinic and Malika sent me a message to say, hey, Miss So-and-so has an appointment with you today. She's due for her injection, but she fell and she's on her way to the hospital. So I'm going to overbook her with you in 2 days just to make sure she doesn't miss her dose. It's just these incredible connections and relationship building that, you know, patients know her name, they've got her phone number, they call her, they text her if they need things. And she's accessible just in ways that I can't be. And so I would say just like the relationships, the versatility, like all the different things and services that they can offer and the passion, and then I would also just say the concordance with our patients. Many of them are bilingual. Many of them, you know, come from the communities that our patients come from. And that's, you know, that's like gold for our patients to sort of see that. And it really builds a lot of trust. So yeah, they're really a tremendous value for our patients.
Thank you. I can see how they do have value and how they're providing it. So thank you for explaining more about that to us. I really appreciate that. Looking at page 5, slide 5, around the different categories that are being measured, gender identity. I wonder what you can tell me about why there's not any data for transgender people who identify as transgender. It may not be particularly useful for what you are capturing on this slide, but that was just a thought.
Yeah, I'll have to take a look at that slide again. I could have sworn that it was there. We certainly ask about that. We do really robust sexual orientation and gender identity screening. We did a big push several years ago because we like lost all of our data between Epic Go Live and the pandemic. So we really had to build our data back up from scratch. And our rates of screening are like 99.9%. So I think the reason is those slices of the pie are too small. And that, sorry, I apologize that they just weren't flagged, but we do collect data on transgender identification.
Thank you. I think it would be really helpful for us to get that that statistic, that data
Yeah.
for the transgender patients because of the, the enormous pressure that
Yeah.
the community is under health-wise and otherwise, so that we can keep an eye on that and integrate that into whatever initiatives the commission thinks about or the department thinks about, making certain that we are understanding the needs and supporting the people.
Absolutely.
And maybe I'll keep it better on this in the future. Maybe we can do footnotes because that is too small to like pop.
Yeah, absolutely. Yeah, we can get you more granular data on that.
Yeah, I so
Yeah.
appreciate we've had that in other aspects to populations that, like 1% or something like that
Yeah.
don't really show up on a
We can get that.
slide.
Absolutely.
Really interesting to hear about slide 9, where you're talking about the incentives for families to participate in this really critical initiative that you have. The honeycomb clinics really, we've heard a little bit about that before, but thank you for highlighting that here. And are those clinics located within multiple locations, or are they kind of standalone on their own?
So the Honeycomb Clinic is embedded in Children's Health Center,
Embedded.
which is our only dedicated pediatric clinic that we have in primary care. Other sites in primary care do care for children, but they're family health clinics, so they care for all ages. So I think the Honeycomb Clinic was really implemented at Children's Health Center because it's our largest contingent of pediatric patients, and a dedicated pediatric clinic. That's sort of all they do, care for kids.
Great concept. Is that a concept that exists, or is this something that you've put together in this context?
A great question. And I don't want to take credit for it because this was really all the Children's Health Center. And it's one of the lovely things about having a close partnership with UCSF. So I think this was sort of developed primarily by the UCSF physicians and faculty member in conjunction with DPH staff that work at that clinic, just sort of designing the model, advertising it, working out all the operations, because it is kind of, tricky. How do we make sure that the right patient goes in the right slot with the right provider? So that was really all Children's Health Center. I deserve no credit for it. But yeah, that was really born out of their, their creativity. And I think also hearing feedback from patients, it was pretty clear that was a service patients wanted.
What a great concept, a great idea. And, I wonder if it can be adopted across the network. For adults.
Absolutely.
And
Yeah. Now that we have a model, I agree.
Especially looking at the next slide, slide 10, where you talk about the disparities and how you're explaining to us how the dissatisfaction rate has gone down based on interventions that you and your colleagues have instituted. And I'm sure that I would imagine that in this feedback, the feedback was separated by ethnicity and race and ethnicity and sex
We're able
and
to break
gender
that
and all
down.
of that. It would be interesting to know. I fully appreciate the way that you've presented it. It's very clear and makes a lot of sense. It would also be interesting to know, or for you and your colleagues to look at, and you probably do, the breakdown for each of these clinics and you addressing the concerns that each of the different populations expressed, and hoping that in each of the clinics, the concerns or dissatisfactions that had been expressed have been addressed
Yes, correct. Yeah, our care experience team has built out a whole A3 analysis that goes very deep. It includes the qualitative analysis, like I mentioned, sort of, fishbone root causes, and they've used that to develop countermeasures. I'm happy to share that A3 with the commission if there's interest.
Yes.
Yeah, but they've gone really deep. We're
Should
very
have some
proud of them.
appendix.
Mhm.
That would be an appendix. I'm
Absolutely.
sure.
Yeah. Yeah.
Yeah. So thank you. What great work. And thank you so much for what you're doing for our community.
Thanks.
Thank you. I just have a couple of questions, but I really appreciate the breakdown with my questions that you received this morning and that you got the answers, particularly with the youth clinics.
Yes.
Which is great. But there are a number of wellness clinics in a number of high schools that are not on here. Do they have staff, let's say at Lowell or others, other than Balboa, that have any DPH staff, or are they just on their own?
It's a great question. I'm not sure about DPH wide. I can say not DPH primary care, and
Right.
great question about why Balboa, why not, other high schools, why some medical schools, but not others. I don't know the full history, is something I can certainly ask about.
I would just be interested just because as a clinician, I refer and coordinate with Galileo and Lowell particularly.
Yeah.
And I never ask them where they're from, who is paying them or what staff they are with, but they're excellent. And I'm just curious on that.
Yeah, it's a great question. I
Since you
can ask
have,
about that.
over 13,000 youth being served in the clinics that's a lot of encounters for.
It is. It's a lot of
kids. So
encounters.
that's, it's a population we want to make sure they
Mhm.
are treated. I have one other question that on slide 4, when I had asked the question about the over 100,000 encounters are not billable. And I understand that, but my question is, in the warm handoff that we're talking about with the health provider or the mental health
Mhm.
provider, is that mental health provider able to bill on the same day? I didn't think so, because I know we can't do that. We have
Yeah.
to. So is the mental health provider then not able to bill if the primary care provider billed?
Only for same day services. Yeah. And so, if the patient comes back the next day, they
That's
can
right.
bill. Yeah. But unfortunately, because we're an FQHC, we can't do same day billing. The warm handoffs, having said that, don't necessarily translate into like a 30-minute visit.
No.
It can be a quick touch point. Hey, like, great to meet you. Here's my name. Here's my card. Does an appointment next week work for you? Just doing a brief assessment and then doing a full visit, at the follow-up. So it just depends a little bit on the need. Certainly if the patient's in crisis, you have to drop everything and take care of them. But if it's sort of a mild to moderate, the warm handoff can just be a brief connection that increases the show rate later on.
I mean, that's what we do in a number of our outreach clinics, pediatric clinics, is the warm handoff. And then up to 5 bridge appointments can be made and then send to other resources. But then the appointments are made on another day because of the billable issue. But, a 30-minute, like you said,
Mhm.
just to stabilize somebody for a brief period. In the 100,000 non-billable, other than, let's say, the mental health, what are some of the other, obviously the mental health, is that a good portion of the 100,000 non-billable?
The mental health. No, I think that would probably be a pretty small portion because otherwise we do bill for services, as long as it's not same day. The non-billable tend to be more nurse visits. We do a lot of nurse visits, whether it's for chronic disease management, like titrating blood pressure medications or wound checks, or drop-in just to be triaged by a nurse. So that there's a fair amount of volume from that. We have an amazing team of clinical pharmacists that also help us with chronic disease management, getting diabetes under control and so forth. We can't bill for those visits, so there's a chunk of that. Medical assistants who will see patients, for immunizations or other sort of routine things. That's another chunk. Yeah, we can't bill for those. Having said that, you asked a great question about the global payment program, which was really developed to incentivize health systems to invest more in these sort of traditionally non-billable staff members, because that care is really important too. It can't just all fall in the PCP. So we don't global payment program doesn't mean we get like paid for a medical assistant visit, but it is, as you saw, like it is a lot of money. And there's a kind of complicated point system that looks at the number of non-billable encounters and what kind of staff member was it that translates into money for us through the global payment program. So there's some like indirect incentivization for that.
Which was my previous question, which was on the global payment program. So that can help with
Yeah.
the 100,000 in that. Great. And I think in the IT presentation later, they're working on even more figuring out how more codes to be able to bill in their creative, whatever it is. So that's helpful, that it is part of the global payment program. Okay, great. Yes, go ahead.
The last thing I just wanted to say is like your slide 7, mission and vision for primary care. I just want to express a lot of appreciation for, your 500-member team getting together and all agreeing on this. The team delivered aspect and the culture of integration, so critical, especially, in the work that I do during the day. We see people who have needs across the spectrum, and they're brought to us based on their behavioral health needs. And the lack of integration across the places that they have been seen by in our community is, a source of frustration, but it's also just a source of it leads to our inability to really address their needs in a way that gets them out of the system and enables them to stay out. And so this is it's so important. And I know that the department is working on this, has been working on it. And thank you so much for, making that a part of the goal and the vision and the mission.
Thank you.
No, I appreciate it. And thank you. This is great work, and it's very creative work, when you're increasing the gap in the no-show rate, down up, 6%. I a couple of years ago did work in a pediatric clinic, Bayview Pediatric Clinic, and for a well-child check, until somebody tried to get very creative, it was a 40% no-show rate. And it was tough, to try to get them in. So this creativity and the incentive program, good for you,
Thank you.
to be creative. But I really, we all appreciate the report, and also, as I said before, your explanations were really very helpful.
Thank you.
As well as the appendix.
Great.
So thank you.
That's great. Thank you.
Okay.
We can move on to item 5, emerging issues. Any public comment in the room on this item? Anything from you, commissioners? Okay, and then we have general public comment now, which would be public comment on something that's not on the agenda. Anyone in the room? All right, so now we can consider a motion for adjournment, please.
So moved.
Second.
All those in favor?
Aye.
Aye.
Thank you so much, everybody.
try to help you.